Hello, my name is Carol Tran. I'm an oral health therapist from Brisbane, Queensland, Australia. I've been practicing now for 20 years as an oral health therapist, and we co-own the oral health home with Lee Harrison Barry and myself. And in today's lecture, we're going to go through from tube to toothbrush and giving tips to carers and professionals that might be interested in trying to care for someone who might have sensory needs as well as additional risk factors that might put their mouth in jeopardy and their overall general health in jeopardy for deterioration and any further things like that. So why does oral health care matter? In today's session, we're going to go through about how oral health interacts in complex care cases. We're going to go through barriers and risks associated with general health and oral health risks, including tooth decay and gum disease. We're going to introduce a new term called oral hypofunction and how that interacts with general health. Big hint is that it goes through about chewing factors as well as how it interacts with your overall general health as a window and a snapshot to how you're going overall in your general health well-being. Following that, we're going to go through some practical oral care strategies. In particular, I'm hoping that everyone will go away by the end of this lecture and get some real-world tips that they can adapt straight away and use either on themselves or their loved ones or on their clients. So who is this session for? We're hoping that anyone that supports with a tube-fed patient, if they have an intellectual disability or choose to be tube-fed, that they understand the interaction between the mouth and the rest of the body and the implications of being tube-fed as well, and some additional needs that they might have. So parents and carers, support workers and nurses, allied health professionals, and anyone who's supporting care at any age. So why is oral health often missed? Well, quite often medical priorities can dominate overall oral health needs. What that really means is that burnout is a real thing. So by the time you've attended, 100 appointments by the end of each year, or, several appointments throughout the day, and you're in and out of the car all the time, quite often brushing your teeth is quite often the last thing you want to do before you go to bed. And especially if someone's dependent on you for care, brushing their teeth is one of the last things to do before the end, and everyone's really tired. So it leads to real fatigue for everybody involved. Sometimes there's extra sensory needs and sensory demands as well, where there's sensitivity in the mouth, which limits everyone's energy and tolerance levels, which leads to, trying to do a quick job to make sure that we are ready for bed and we can go to bed relatively easy as a part of our evening routine. The final part is that oral health care is often seen as non-urgent. What that really means is that it's not a problem until it becomes a problem. So someone has bleeding gums, behaviors, especially if they're non-verbal, that can't be explained by any other medical conditions, that oral health care isn't seen as urgent. Everyone knows it's important, but it's not urgent. But if it's not done day to day, problems can accumulate very easily, very quietly. So why does oral health still matter? Well, if you think about it, when you meet someone for the very first time, their smile is usually the first thing you'll notice over their eyes and any other facial features, because the smile indicates that this person is safe, I can approach them, and there usually is a window to how their overall health is going as well. So the social impacts of healthy teeth and healthy gums and a healthy mouth overall are huge in a social impact sense. What's also interesting is that your oral health is linked to your respiratory health. So especially for people that are tube fed, quite often respiratory diseases are very common. The bacteria that end up in your lungs that causes respiratory problems actually originate from the mouth. What you do when you brush your teeth every night is that you remove that layer of bacteria that can cause infections throughout the whole body. So why we're looking after each person's mouth is to actually prevent infection and pain later on. So what happens is that if someone is tube fed and not brushing their teeth, what actually happens is that we actually accumulate a lot more bacteria faster than someone who chews and brushes their teeth regularly. What that means is that the lack of chewing means a lack of oral ability. So if you think about every time you chew, you're actually exercising the muscles around your mouth as you're putting that chewing action together. So the lack of chewing means that the lack of muscle is actually being used around the mouth. And in numerous studies, it actually has shown that the reduction in chewing actually reduces blood flow to the brain. So it can accelerate things like cognitive decline and dementia risk as well. So this impacts anyone who's chew fed and also on textured modified diets because the lack of chewing results in the muscle atrophy around the mouth. And if you combine that with someone who's taking medication regularly, so any two medications, quite often, anticonvulsants, antihypertensives, epileptic medications can lead to dry mouth. So if you take any medication, any two medications or more, it actually reduces your quality and quantity of saliva. For those I describe who's never experienced dry mouth, is that imagine waking up after you've had a long sleep throughout the night, and you notice that your mouth is quite dry. What happens with someone that has a chronic dry mouth problem, which is known as xerostomia, is that this actually causes the plaque, the bacteria in the mouth, to become sticky and accelerates tooth decay and gum disease because the bacteria quantity and quality change because of the lack of saliva. What's also noted as well is that you actually increase the risk of tooth decay and gum disease, so bleeding gums and holes in teeth, if you rely on others for care. So we want to make this process easy for everyone involved so everyone gets a decent brush and looking after their teeth long term. Common barriers that we quite often deal with in our day-to-day practice is real sensory issues because if you think about it, the mouth is one of the most sensitive parts of the body. So sometimes trying to read a social story as a part of a way to engage toothbrushing or doing some fine motor activities without hearing it actually putting the toothbrush in the mouth or unpacking why that client has a toothbrushing issue can be a real barrier to trying to learn how to brush someone's teeth. So quite often we'll actually try and break down the problem by saying, why is there sensitivity issues with brushing the teeth? Is it because it's a toothpaste? Is it the taste? Is it the texture? Is it the fact that, when you actually put the toothbrush on the mouth, they don't like the sensation of the bristles that touch the gums, not so much the teeth? Or is it because, as a child, quite often, if there's intellectual disabilities and a lack of cooperation with behaviors, is that some people will actually hold them down to brush their teeth, and that will will have significant impacts in distress or trauma as well. And the resistance as they get older and they become bigger, that behavior exacerbates, and they choose not to brush their teeth at all. The common barriers that we see for care and context is that by the time they see us, there's real medical fatigue. They've seen lots and lots of health professionals, and by the time you need to deal with a dental professional, it's probably the last thing in your mind. For carers and parents, especially when there's a resistance to toothbrushing, it's not wanting to cause distress on the patient on your loved one who is tube fed as well. So that's like, oh, let's not do it today, or let's just do it quickly because I don't want to cause any more distress. Combine that with a lack of confidence. And in this lecture, that when we're targeting, we're not after perfection, we're after just consistency in terms of training someone to actually care for someone's mouth. And how do you know you've actually brushed your loved one's teeth well? Apart from the obvious signs of bleeding gums and a lack of bad breath, we don't actually know until we actually go to a dentist for a checkup because we can't see the plaque in our mouth. And when you're thinking about someone who has complete care dependency on others, toileting, showering, and other personal hygiene measures often competes with decent oral health routines as well. We know that oral health routines take at least a good 5 minutes, if not 10 minutes, But if we can incorporate that routine as a part of the oral, overall hygiene routine, i.e., can you brush someone's teeth in the shower or as you're giving them a bath or as a part of a potentially toileting routine as well, then that actually makes something easier. So we don't ask people to make a separate routine for their oral health, especially if they're dependent on others for care. Just make it a part of some other routine, i.e., toileting, i.e., showering or bathing. So we really want to put oral health into context is that we don't want to be completely perfect when we're doing trauma-informed care, is that we just want to start with and find out what is tolerated. If currently you know someone or yourself can't tolerate toothbrushing, we start from very basic principles. It's like, can you just face wash with wiping your lips? If not, can we start off with wiping your cheeks before we actually go into the mouth? Because small steps matter. Progress looks different for everyone, and what we mean by that, for someone with an intellectual disability, plus being tube fed, plus being non-verbal, quite often will say that this process to desensitize someone and accept a okay oral hygiene routine will take a good year. But the fact is that we are making small progress, and that is massive for everyone involved. So in our practice, we have a very much a trauma-informed oral care lens. Is that we want our clients to be able to safely be well with us and be able to predict what we're going to do. So as a part of your routine, if you are trying to desensitize someone to accepting a toothbrush or accepting a wipe in their mouth, that means it's like, let's talk about safety first. Do they feel safe in your presence, or do they actually start showing distress behaviors? If they are showing distressing behaviors, going, tremoring, looking away, showing other resistance behavior, then we want to give them a sense of choice and control and stop before it becomes distressful for everybody. Because trying to build up a good oral hygiene routine will take time, and trust is more important than actually doing the oral hygiene routine, i.e., brushing, perfectly. So we want prevention over perfection. We want comfort over technique. We want to reduce the reduction of risk over time. We want to be sustainable in our routines, and we want consistency over duration. So what that means is that you don't need to use a toothbrush all the time. The key component is that we want to remove the bacteria in the mouth. So that includes removing the bulk of the bacteria. It doesn't matter how you remove it. It can be done as simple as using a baby face wipe to clean over the teeth compared to using a toothbrush. If someone is tube fed but they still take things orally, you want to actually be checking as well what is a part of their texture modified diets. Are there biscuits involved? Is there still cordial? Is the cordial full sugar? Because that component, a liquid sugar without chewing, can actually accelerate tooth decay quite fast. We want to make sure our routines are sustainable, so it's easy to follow, and that there isn't a possibility of causing anyone involved distress. And the fact is that we want to make it consistent, so the true fed client is able to predict what's going to be happening when a toothbrushing or oral hygiene routine needs to occur. I want to introduce a concept called oral hypofunction. So this research comes out of Japan and is being adopted in Asia quite widely. And what they're looking at is oral hygiene as one of seven factors in terms of what is the overall function of the oral system. So the questions are, can they chew food without any discomfort? Is there a choking risk because they can't chew? Can they talk and communicate clearly? Because what happens with time and as we get older, but especially for people that aren't chewing, there's an atrophy of muscles around our mouth as well as our tongue. So quite often when we actually are having a look at tube-fed clients, is that sometimes there is a tongue thrust because the tongue with someone with an intellectual disability tends to thrust and chew with their tongue with their food, or they're not using their tongue at all, and so there is mouth breathing involved as well. So the term oral hypofunction is a reduction of function of chewing in the mouth, and that has huge implications in terms of someone's overall general health context. Because if you think about it, the mouth and eating with chewing is the first stage of digestion. It actually sends signal to your brain and to your digestive system to prepare to actually accept nutrients as you're swallowing. So if you are being tube fed, you're actually missing the first stage of digestion. You're missing that part and the brain to say, hey, there is some nutrients coming. And so the ability to actually eat more actually increases if you don't chew your food and you have either been tube fed or on a texture modified diet. So there are implications for them. We're not saying don't tube feed people, but we are saying it's like there are factors that we need to consider. If the mouth isn't chewing, can we do some exercises that encourages the muscles to be maintained as well as decent cognitive health as well? So why does it matter? Because the fact is that when you chew, you actually naturally remove the bacteria in your mouth. You might have heard the term, an apple a day keeps the doctor away. And there is some truth to that. The fact that when you chew, you actually stimulate the saliva in your mouth. So it actually increases the ability to clean the bacteria off your mouth, it's called plaque, by 20%. So if you chew gum for 30 seconds, without brushing your teeth, you actually naturally remove 20% of that bacteria that's already sitting in your mouth. So for someone who's tube fed or not using chewing actions in their mouth, that bacteria actually accumulates faster if they're not chewing. So some key messages on plaque is that plaque to the naked eye is almost invisible. When you first brush your teeth, it actually removes the layer of bacteria on your teeth, and it is invisible, and it actually takes 3 days for actually plaque to form enough so you can actually see it on someone's teeth. So how can you tell you've got plaque on your teeth? The easiest way is actually to pop your tongue on top of your teeth in front of the front surface and actually run it across. The tooth itself should feel smooth and glossy, but if it feels rough, matte, and furry, that means it is actually some bacteria stuck to your teeth. Why does that matter? Because that bacteria has evolved with us so efficiently and effectively that it can actually enter your whole body if it's left undisturbed. So what is plaque? It is actually a structured and sticky substance. So think of it as a mold growing, a slow growing mold on your teeth. And the problem is that the tooth surface, your teeth doesn't shed like skin does. So that's why we actually need to brush our teeth, because the bacteria stick to your teeth so efficiently that it can't actually come off naturally without something brushing it off. So toothbrushing or a wipe, in fact. It actually sticks to your teeth very strongly, and it can only be manually removed. And I'm going to go through that in subsequent slides more in detail. Only physical removal works, so brushing even briefly or cleaning with a wipe is actually essential. So the problem with plaque with tube-fed mouths is that plaque still accumulates without any oral intake. What we hear is that, hey, if someone's being tube-fed and they're not using their mouth because it's nil by mouth, then we don't need to clean the mouth at all. That is completely not true. In fact, the plaque accumulates faster because they're not chewing and they're not eating and they are being tube-fed as well. Because if they're not chewing, you actually reduce someone's saliva stimulation, because the fact you're chewing actually increases your saliva intake, and there's less mechanical cleaning, as I was going through before, that when you chew, i.e. if you just chew anything for about good 30 seconds, you actually remove 20% of the bacteria in your mouth naturally from the action of chewing. So when you combine all of this, a factor that you have you have a reduction in saliva, the lack of chewing, is that the plaque becomes thicker and more problematic than someone who actually is not being tube fed. So oral health is actually a gateway to our overall general health and can provide a snapshot in terms of, like, if you can see there's a problem in the mouth, there can be a problem overall in the body. Particularly someone who might be intubated or tube fed, the oral bacteria actually can cause major problems in your respiratory system, is that it can actually enter your airway. And oral bacteria, especially if it's not removed on a regular basis, is that it becomes a reservoir for bacteria that has a potential to cause a systemic disease. Poor oral hygiene is strongly linked to an increased systemic disease risk, including diabetes, dementia, heart disease, and increasing in cognitive decline as well, including dementia. So aspirational pneumonia risk, especially for clients who are tube fed, this is a real problem. What happens is that when bacteria acts as a reservoir in the mouth, the oral bacteria actually can enter and be aspirated into the lungs, even if it's people that have nil by mouth. Risks increase with people with swallowing difficulties. So that means is that because this lack of chewing isn't removing the bacteria, plus the lack of brushing actually increases the chances of the oral bacteria entering to the lungs instead of going naturally down the esophagus and being killed by the stomach acids. So there is a strong link between dental plaque, so the bacteria on our teeth, to aspiration pneumonia, respiratory infections including COVID-19, and COPD as well. So now that we've highlighted the major issues with the bacteria in the mouth and our overall general health risk, what can we do about someone who isn't brushing on a regular basis and does show some resistant behaviours that they don't want to be cooperating with brushing? One of the very simple ways is that if you can actually use a wipe, so think of a baby wipe that you use to clean the skin. So you might use someone to clean your hands or wipe the mouth after they've had a meal or there's something on their skin. You can actually use a wipe to remove the bacteria off their teeth. And the easiest place to start is actually to wipe around the lips to see if they're willing to accept something being touching their lips. And that might be as simple as all you do on day 1. Then on day 2, you start with wiping the lips and then wiping the teeth. And it's the edges of the teeth, don't go near the gums yet, because the sensation of something touching your teeth is a lot less sensitive compared to touching someone's gum. You can try that right now. If you touch your teeth versus touching your gum, the proprioception in your teeth is actually much less compared to the proprioception in your gum. So for someone who actually doesn't brush their teeth and shows that resistance and is highly sensitive to having anything in the mouth, even if it includes nil by mouth, it's as simple as using a cloth, like a face cloth, but ideally a wipe, a baby water wipe, to actually wipe the bacteria off their teeth. And you don't need toothpaste for this to occur. So what that means is that because most patients who are tube fed are nil by mouth, is that water brushing counts. The cloth is wet and you touch the tooth and you wipe the bacteria off the teeth. The bacteria that causes the most amount of problems is actually where the tooth meets the gum. So where the tooth meets the gum line, that's the bacteria we want to remove, because that bacteria can enter your gums and then enter your bloodstream and circulate around your whole body. Even if you do that 1 second on the front tooth, that still counts. And you want to build gradually, so 1 second per tooth, wipe, and then tomorrow becomes 2 seconds, and the day after that becomes 3 seconds, and you slowly build them up to actually accepting wiping their teeth before you introduce a toothbrush. So in our practice, we routinely use wet wipes as a way to introduce a cleaning routine in the mouth before we introduce a toothbrush. And at this stage, especially if they're nil by mouth, you don't need toothpaste. The other oral hygiene tools that you may or might not be using at the moment. When we actually do a number of home visits and care home visits, is that we observe very large toothbrushes being used for someone is nil by mouth or that is tube fed. The emphasis we want to emphasize here is that small toothbrush heads are the best. How do you know what's small? If you have a look at the Oral-B electric toothbrush head, it really shouldn't be bigger than that. And if your loved one or yourself or someone you currently care for will accept an electric toothbrush, even when they're being tube fed, electric toothbrushes are the gold standard. What that means is that the technique and having a perfect brushing technique is less dependent if you use an electric toothbrush. I myself, as a healthy, able-bodied, neurotypical person, use an electric toothbrush routinely over a manual toothbrush. If toothbrushing is not tolerated, then a wet wipe, so using a baby wipe, to wipe the teeth is perfectly acceptable. Using suction toothbrushes, so quite often if you've got an aspirator or a suction unit with you, having a suction-based toothbrush is a great way as well. And if you are adverse to actually putting your finger in someone's mouth, then an oral swab can do as well. But I would say that in terms of like order of priorities, I'd go from top to the bottom on the lowest. Because with the oral swab, you can't get the sensation of can you feel them brushing their teeth compared to using a toothbrush. Other things that we do here in our practice is that if they're not chewing, then they don't need their teeth to be brushed. Just using a mouth rinse is a great substitute for brushing. That is not true. Please let me emphasize that is not true at all. Mouth rinsing is not enough over toothbrushing. Okay, it does not remove any plaque. The design of a mouth rinse is that it only works in a clean mouth because it actually prevents bad bacteria or plaque from sticking to your teeth. If there is existing bacteria already on the teeth, plus someone is not chewing and is also being tube fed, it cannot replace toothbrushing. So manual removal is still necessary. The key takeaways I want everyone to walk home is that I hope everyone's learnt the new term oral hypofunction. So the lack of chewing, lack of oral hygiene, lack of saliva actually increases general health risks, including increasing cognitive decline risk. So oral hygiene is extremely important. Plaque should be removed daily, and kind and consistent care matters. So even if you take away one small step today, i.e. using a water wipe on your loved one's teeth, then that is a great first step to introducing a toothbrush. If you have any questions, feel free to contact me, admin@oralhealthhome.com, and subsequently I will be able to provide more details on contact. And if you'd like a tele home visit, please let us know and contact us at any time. Thank you for your attention and have a great day.